Good afternoon. My topic is cerebral visual impairment with visual acuity 6 by 6. Is it normal? So we'll see a case scenario. A 9-year-old male child was referred to me by a developmental pediatrician as poor performance in school. Eye checkup done earlier was normal. Vision was 6:6 recorded. Fundus and external eye was normal. But she felt that there was something wrong with his visual response and came for a second opinion. When we took a detailed history, there was a history of hypoglycemia on the second day and history of NICU admission, mild developmental delay, poor performance in school, and mother complains that he bumps into objects while walking and he has difficulty to walk in uneven ground. External eye was normal, but fundus showed a mild temporal pallor. So we ordered for an MRI and it came as a hypoxic ischemic changes with occipital lobe gliosis, and his field was like this. He had a field defect, especially more in the inferior part. So what are we dealing with? So cerebral visual impairment has become a major cause for visual impairment in children. And in simple terms, we say that brain is not able to process what the child is seeing. And it can range from low functioning to high functioning. This is a child with a history of neonatal seizures and not very difficult to diagnose because he has a poor visual response and he doesn't respond even to lighter toys in dark light, and head control is also not attained. So this is a low functioning CVI. Now we will be discussing about the high functioning cerebral visual impairment. Why is it underdiagnosed or missed? Vision is not just acuity of vision. In high functioning CVI, they have almost normal or a near normal visual acuity, but they experience high level visual processing deficit. So lack of understanding of a child's difficulties will make it difficult to diagnose, and it will be misunderstood as a learning disorder, behavior disturbance, or an autistic behavior. So what is higher function visual deficit? From the occipital lobe to posterior parietal lobe goes the dorsal stream. And when anything happens in this stream, that will result in motion deficit, inability to see in crowd, poor spatial awareness, and inaccurate reading. And the ventral stream, which connects occipital lobe to the temporal lobe, is involved in visual memory, face, and object recognition. So we'll see how a child with CVI see. They can have a blurred vision, difficulty in recognizing face, tubular vision, inferior field defect, and difficulty in seeing moving objects. The cognitive dysfunction they suffer include optic ataxia, that is, when they see a thing, they will have to move and take it, but that will not be possible. Simultaneous agnosia, difficulty to identify multiple objects at the same time, difficulty in seeing in a crowded place, and difficulty in using multiple senses at the same time. When you are talking to him, he will be looking away, and when you want to speak, both visual and auditory won't come together for him. How to diagnose this? History. A proper history taking is very, very important tool because all these children will have some reason for brain injury. A clinical examination will be usually normal except for optic atrophy in some cases and some refractive error, strabismus, or accommodation anomalies. Radiology, as Dr. Chaitanya has extensively told, can support our diagnosis. A normal vision and MRI no longer excludes the diagnosis of a cerebral visual impairment. A detailed history can be taken from the questionnaire regarding any insult in the neonatal period, postnatal, or infantile period. And a detailed questionnaire, which is developed by Professor Gordon Dutton, this is what we follow. It includes a lot of questions related to each of the difficulties that the child is having. We'll go through a few. If the parents reports of a visual behavior like child trips over the toys and ground, they have difficulty walking downstairs, difficulty climbing up the stairs, they'll be comfortable, but they won't slide down, trip at the edge of pavement. All this indicate that the child may have a lower field defect. Other questions like reading difficulty, whether they find difficult to find toy from a toy box, difficulty in identifying the family members, change in behavior in a crowded place, difficulty in identifying shape. So how will you evaluate this? You don't need any sophisticated instruments. You need just few toys like things like balls. They ask them to separate it with colors, ask them to identify it. You have Leah's mailbox or puzzle box. They can identify the shape and size. And a Vikas app developed by the Mindtree and the Aravind, that is a very good tool. From that, we will be able to diagnose any visual abnormality behaviors, recognition of shape, and they give training also in that. This is a child doing the Leah's mailbox, and Vikas app he is trying to do. Training also gives in same. You have to go with the child and see how he walks in a place where there is a small toy alley in the ground, how he walks downstairs, how he is reading. All this will help to come to a diagnosis. This is a 4-year-old preterm child with developmental delay. Leah's box he is able to puzzle, he is able to do, but when it comes to a little more complicated things, he is not able to do it properly. This child with history of seizures, he is having an optic ataxia. He is able to see he want to pick the torch, but he finds it difficult to do. The test for simultaneous agnosia, you can either use the Ishihara chart. They will be identifying the dots, but they won't be able to read the number. And they will be identifying the small t's, but they will not be able to identify the H made with that T. MRI shows the PVL changes is the most common finding that you see. Other findings like occipital gliosis and a diffusion-based imaging will show the ventral as well as a dorsal streams defect. Coming to the management strategies. The basic treatment of CVA is training. What works for one child may not work for others. You prioritize the findings in them and implement 1 or 2 at a time. For example, if they have a difficulty walking downstairs, highlight the edges like we have done in our hospital, use bright light, minimize wall decoration. At the level of eye level, you can place something that is catchy for them, keep the floor surface clear, ask them to hold the elbow of the parent so that they will be able to know the difference in the floor space. For learning difficulties, you can highlight the numbers like this, use 3D tools, and you can make windows so that will be highlighted. You have to reduce the clutter and highlight the objects. Suppose a child is having a difficulty in catching ball. It's not because he is lazy, because he's not able to see a fast moving object. You train them with balloons which are slow moving or ball with sounds and lighted. And you have to reduce the clutter if they have a difficulty in finding objects. And in the top of a slide, they have difficulty sliding down. Start with smaller slides, gain confidence in them, give them verbal reminders to tilt their head so that they will be able to enjoy the park. If they have reading and writing difficulty, use finger to tracking. Slanting reader can be used where there is a lower field defect. Use typoscope and present material in small sections. So what is our role as ophthalmologists? A high degree of suspicion should be there if any neurological insult is there. Manage the coexisting ocular condition. Understand the need and visual problem of each child. Observe, spend time with them. If you are in a busy OP, call them another day when you are relatively free. It will take around 45 minutes to 1 hour to evaluate and give the report to them. Counsel the parents and for the compensatory strategies and the environmental adaptation they have to take in school as well as at home. Work in team with the educational and therapeutic team. So it's basically a multidisciplinary team approach. You have to work along with the pediatrician, the neurologist, therapist, and most important parents because they are the best therapists for the child. Train your child to use vision in a meaningful way. Thank you.